The next question, Gil, I think is a really interesting one. It's a bit of a scary one, I think, for patients because I think they noticed on the Secure IBD website and on your graphs that the five ASA medicines, mesalamine or sulfasalazine or other medicines like that, people on those medicines seem to have a higher risk of death. And I know this is something that you addressed in the paper that you just had accepted. Can you talk a little bit about why that might be?
Yeah, no, absolutely. It's such a good question, and I'm glad someone asked it so they have an opportunity to answer it. So first of all, we have to think about the methodology of these types of studies, and not just the specific registry, but a lot of type of work that both Eric and I do. There are potential flaws in designs of studies that sometimes bring out associations or relationships that may or may not be true. And you see a lot of this with the COVID literature. You see on Twitter or even the news media, something comes out, like for example, there was a recent article that said if you smoke, you were protected against getting bad outcomes of COVID. That was published in the news, and some very smart epidemiologists actually went through the paper that was unpublished and actually went and said, you know what, here are some of these methodological flaws that actually would explain why they're seeing these findings. And so every time that we see a relationship, we always have to ask the question, is it biologically plausible? Does this make sense? And so mesalamine, drugs like Pentasa, Asacol, Mesavant, Salifog that we use quite commonly to treat particularly ulcerative colitis, less so Crohn's disease, but for the most part ulcerative colitis, are topical immune suppressants, meaning they suppress the immune response in the bowel, but they don't suppress your immune system systemically. We've known that for a huge number of studies. So there's actually no kind of biological reason to think that a drug like Pentasa would actually put you at a higher risk of developing a bad outcome from COVID. So then the question is, why would a study like this actually show something like that? Well, the answer is, and what we think the answer is that this was a global study. This was a study that was done all across the world. So we have people who are from North America where they have access to some of the best care physicians, the best drugs like Remicade and Entyvio and Humira and Stelara and Xeljanz. It also comes from countries in much poorer countries where you still get inflammatory bowel disease, but access to care, access to drugs is a lot poorer. And we know in those countries, they use a lot more of the mesalamine drugs, the drugs like Pentasa, Asacol, Mesavant. Just the access to those drugs are much cheaper. They're easier to access. We've seen in our database that a lot of the people who are on Crohn's disease were getting these medications. And in North America, we actually use a lot less of this than in Crohn's disease. And so what we're thinking is that in these countries where you don't have access to the best care and they don't have access to the best drugs, you may also not have the best access to care for your COVID if you get sick from it. And we think that those things are correlated together. And so we see that this happens more commonly, this drug is prescribed more commonly in poorer countries. And also we saw that it's prescribed more commonly in our older population where many physicians might be nervous to use a drug that suppresses your immune system. And so they may actually be suboptimally treating them with a drug like Pentasa, where really they should have been using a drug like Entyvio instead. And so this is what we explained in the paper. Having said that, it's piqued our interest, and we are doing a series of different studies trying to understand, exactly is this truly a risk or not. But right now, based on our understanding of where this data comes from, and just does it make sense kind of bar, we don't feel that a drug like Pentasa increases your risk of a bad outcome.
That's great. And I always like to show this. I'm hoping that people can see my screen right now. This graph, the classic graph, right, that an epidemiologist will show to the public to explain that correlation does not equal causation. And this graph shows that there's high correlation between years that a Nicolas Cage film came out and the number of drownings in the United States. Clearly, well, you could argue maybe Nicolas Cage shouldn't be making any more movies and then we'd have fewer drowning, but that's not the case. There's other reasons maybe Nicolas Cage shouldn't be making any more movies, but clearly this is a correlation, but it's not causative effect. There's other things that could explain this association. And so it's important that people understand that this may not be an issue of the drug itself here. It may be an indicator of some other health services effect or health system effect.
And I just want to add that I think Nicolas Cage is being casted as the Tiger King. So we may see more drownings in the US once that show comes out.
Absolutely.